Okay, Sakshi, start presenting your case.
Yes, sir. Sir, may I start?
Yes, Sakshi, continue.
Good evening. Myself Sakshi, and today I will be presenting a case on PVD. Jnanoba Kavthale is 79 years old male. He resides in Olandi, Islamwadi. By occupation, he is a farmer and he is educated up to 4th standard. Chief complaints: pain in right calf since 4 months and wound on right toe since 1 month. HOPI: patient was apparently all right 4 months back when he started experiencing pain in right calf. The pain was insidious in onset and gradually progressive in nature. After walking, patient experiences cramping pain and he has to get rest to relieve it. The pain is more at night, it wakes him up. In order to obtain relief, he repeatedly applied heat, resulting in non-healing wound over the heel. Wound is present over the great toe since 1 month. It is sudden in onset and associated with no discharge. HOPI: no history of fainting, transient blackout, blurring of vision, no history of chest pain, no history of abdominal pain after eating, no history of pain and weakness in upper limb, no history of trauma, no history of low back pain radiating to the legs, no history of dilated tortuous veins. Past history: patient had similar complaints in past for which he was hospitalized. Yes, ma'am.
No, continue, Sakshi. Continue with your history.
Yes, ma'am. Past history: patient had similar complaints in the past for which he was hospitalized multiple times. Patient is a known case of diabetes since 20 years and he is non-compliant to medications, oral hypoglycemic agents. 1 year back, he underwent thrombolysis at a private hospital in Shirdi due to complete lumen occluding common femoral artery. This year, in the month of March, underwent fifth toe amputation. There's no history of hypertension and no history of asthma. Personal history: patient is a BD smoker for past 50 years. He smoked almost 2 to 3 BDs daily and is continued even now. No history of alcohol consumption. Vegetarian diet consumed. The bowel bladder habits are normal and his sleep is disturbed due to the pain. Family history: history of diabetes in elder sibling. No complaints of coronary artery disease in family. No history of hypertension and asthma in the family. Summary: 79-year-old, known case of diabetes since 20 years, non-compliant to medications, and smoker since 50 years, presents with pain in right calf since 4 months, and ulcer on great toe since 1 month. Ma'am, may I read the examination part or should I stop
No.
here?
Let's go to the history again.
Okay, ma'am. Yes, ma'am.
Next, history of presenting illness.
Yes, ma'am.
So, what is rest pain? Sakshi, what is rest pain?
Ma'am, rest pain is a continuous aching pain. It usually does not respond to analgesics and like it is present throughout the day and night. And it is also known as the cry of dying nurse.
Okay, why does rest pain happen? Why does pain happens? In this patient, what are the reasons do you think why the pain happens?
Ma'am, actually, the history is like the patient, whenever he's performing some kind of like activity, whether be it walking or exercising, it's like there's an occlusion due to the atherosclerosis. So whatever the demand is there, it is not being like fulfilled. I mean, there's a misbalance between the supply and the demand of oxygen.
So what is the specific reason for rest pain?
Ma'am, even the nerves, they are not able to get the blood
Yeah.
supply.
The starting phenomenon is substance P gets accumulated. Because of substance P, the pain happens. But when the rest
Yes,
pain
ma'am.
comes, it is because of the crying of the dying nerves.
Yes, ma'am.
Yeah. Do any classification, matlab anything, how do you how you tell the pain in PVD?
Ma'am, Boyd's classification,
Yes.
Fontaine classification. Ma'am, Boyd's
Boys.
classification, there are three classes in it. In first, the like patient when is walking, he's experiencing the pain and it is disappearing. In grade two, the patient is walking, then he has to, the pain is persisting, but still he's able to walk. And in grade three, the pain is very severe that it is compelling the
Take
patient to
this
take
one.
rest.
Yeah. Fourth one is the final thing is even the
Rest being
patient.
can.
Some people says that there is four. Some people doesn't say it is four. You know any other classifications specific
Ma'am,
of this thing?
Rutherford, Fontaine and Rutherford classification.
What specific thing does Fontaine have that Rutherford doesn't have?
Ma'am,
Anything?
claudication distance, like minimum
Great.
pain-free distance.
Great. Fontaine specifically tells about claudication distance, so it is very easy to use every day. So that in the patient
Yes,
terms, it
ma'am.
is very easy to find the Fontaine classification. Fine.
Yes, ma'am.
Sakshi, any significance of age?
Sir, increasing age is a risk factor for this type of condition, like due to the calcific changes.
Which condition? Which kind of condition?
For developing atherosclerosis.
Okay.
Okay. Any other?
Sir, for
Why not?
PVD, there are Sir, for PVD, there are different etiologies. So, like, if it is atherosclerotic, it is more common in old age. Usually, in like Burgess disease, it's most commonly seen among 25 to 40 years old. So,
No, do Burgess disease is only less than 40. In 50 years, if a
mm,
patient comes with 48-year-old coming with all the features, is it not Burgess?
it is, but ma'am, most commonly, like, it is amongst those
Do you
who
know
are
any
around.
criteria for Burgess? There's a criteria. Based on that criteria, you will tell whether the patient is having Burgess or not.
Criteria for Burgess.
There's a criteria called a Shinoy criteria. Shinoya. Based on criteria, if the factors of all the factors, there will be 5 factors in the criteria. If the patient fits in all the 5 factors, then only you will call it Burgess. Then in that Shinoy criteria, it tells patient less than 50 years. The specifically tells patient less than 50 years.
Okay,
So,
ma'am.
if a 48 or 50-year-old patient comes, your DD can be Burgess. Before it
Okay,
was
ma'am.
told it is less than 40 years, but now all the papers all tells it's less than 50 years.
Okay, ma'am.
Yeah, it's Shinoya criteria.
So, any significance of sex, Sakshi?
Sir, the PVD, like this, it is more common in males as compared to females.
Okay. Any other disease predominantly involving females with upper limb involvement?
Sir, Raynaud's disease is more common in the females.
Okay. So there is a Raynaud disease, and also there are multiple connective tissue disorders which are more common in the females.
Scleroderma, yes,
Yes.
ma'am.
Sakshi, can Raynaud's happen in lower limb?
Mm, yes, ma'am, it can occur, but more commonly it occurs in the upper limb.
Can TAO happens in upper limb?
Thromboangiitis obliterans, yes, ma'am, it can occur in upper limb.
Yeah, many of the researchers tells the counterpart of TAO in upper limb is Raynaud's. Now that is the accepted theory.
Okay, ma'am.
So what is this typical pain is
What are
called? What is this typical pain is called as, Sakshi? You have described all this pain and everything. So what is this typical pain is called as?
Intermittent, sir, it is intermittent claudication.
So before it was intermittent claudication. Now your patient is having rest pain.
Rest pain. Yes, sir.
So what is the definition of
Any other
claudication?
name for any other name for intermittent claudication? Are Sakshi?
Limping type of pain, maybe.
No. Any specific thing you will? It was also known as vascular claudication. For only vascular claudication, intermittent claudication can be used. Neurogenic claudication can never be intermittent claudication. So intermittent claudication and vascular claudication can be used in same. It is both are same.
Okay, ma'am.
Yeah.
So, what is the definition of this claudication, Sakshi?
Sir, claudication, it is a cramping type. It should satisfy like three stuff. Number one, it should be a cramping type of pain. Second, it should start when the person is walking or exercising, and it should stop like when the patient has stopped that particular activity.
Yeah, so it is a kind of reproducible pain.
Yes,
So it is a cramp-like reproducible pain predominantly involving in the lower limbs and at the calf region, which aggravates while doing exercise or any work, strenuous exercise work, and it relieves after taking complete
yes,
rest.
yes, sir.
So this is the classical example of your vasculogenic claudication. So do you know other types of
Yes.
claudication?
Sir, like arterial claudication,
So
venous
this you are
claudication,
described. This is arterial
neurogenic.
claudication. Any other claudication?
Yes, people do it for 2, 3 months. Neurogenic and osteogenic claudication.
Okay, so how will be the osteogenic claudication?
Sir, osteogenic claudication is like the patient would experience pain on taking his first step.
So pain while taking first step is your predominantly your osteogenic claudication.
Osteogenic claudication. Yes, sir.
Okay, so what how will be the pain of typical pain of neurogenic claudication?
So neurogenic claudication, the patient would feel pain in one particular position only. Like for example, in lumbar canal stenosis, when the patient is bending forwards, that would relieve his pain.
So what will be the character of pain in that neurogenic claudication?
Sir, sorry, I was not able to hear.
So what is the type of
What is the
pain?
Type of
type
pain.
type of pain in neurogenic claudication?
You told no vasculogenic claudication
Dull
will be
aching.
cramp-like pain. No, in neurogenic
The
claudication, no, patient will be having predominant pain
dull
of no, not dilating. It is a sciatica kind of pain, sharp shooting type of radiating pain from back to your lower limbs.
Okay, sir.
So because of your lumbar canal stenosis.
Sakshi, you have not told aggravating and relieving factors postural change in your history.
Ma'am, I have mentioned that the pain is more at night and it wakes him up.
No, postural change is also important, right? Diurnal variation is important. Postural change is important. What
Yes.
is a specific type of posture he tells the patient tells that he is not experiencing less pain in PVD?
Ma'am, when he is hanging his limbs by the edge of the bed, like
Whereas
his
in
pain would
whereas
get
in
relieved.
whereas in varicose?
Elevation of limbs would relieve his pain.
Yes.
So
So you have to mention
what kind of pain will you get in the you know, venous claudication, Sakshi?
Sir, it would be a dull aching kind of
No,
pain
in
and it would be like
venous claudication due to
venous
DVT.
claudication.
So you'll be having bursting type of pain.
bursting type of. Yes.
Severe bursting type of pain will be there in the DVT patients.
Yes, sir.
So you are telling this patient, no, this patient is having now rest pain. Suppose
Mm,
if you are having two patients, one patient is having claudication pain and one patient is having rest pain.
mm.
How your management will differ in
Yes,
these
sir.
patients?
Sir, if the patient is having claudication pain, then we would be first try to go with the mm, like we would advise him to stop all the etiological factors, whatever are aggravating it.
So your management will be more likely towards your medical line of management.
Yes, sir,
First, you
medical
will start with
management.
your conservative medical line of management. But now, if your patient is having rest pain, so there is a no any role of medical line of management in this patient. So your patient either should go
Yes,
any
sir.
kind of some intervention. And your
Yes, sir.
rest pain is also one kind of surgical emergency. If you don't treat
Yes.
rest pain, what will happen next? Your patient will develop tissue loss,
Gangrenous,
tissue,
it would
tissue
turn
loss,
gang.
either in the form of ulceration, either in the form of any kind of infection, or either it kind of any kind of gangrene.
Yes, sir.
And also your rest pain signifies that during claudication, like previous it was claudicating type of pain, no, there were collaterals, multiple collaterals were there, but now rest pain means those collaterals were also blocked and it is not helping the patient to supply the blood to the underlying muscles and skin.
Actually, the
Yes, sir.
collaterals are not blocked. Sakshi, the collaterals are also vessels. How does this collaterals differ from the normal vessels? Any idea?
Ma'am, I think that they are not able to compensate for the supply, but they will like
No, no, no,
help
no,
in maintaining it a bit.
no, no, no. Suppose if a patient comes, most of the in our setup, most of the people comes, the Doppler shows the patient is having no flow in the artery. But
Hmm.
not every patient is having ischemia, not every patient is having gangrene, because the collaterals are very well formed. The collaterals is a beautiful phenomenon. It keeps the limb alive. But after some time, the collaterals gets exhausted, as Sir said. But what is the specific thing of these collaterals? Do you any idea how are collaterals different from the normal vessels? The collaterals doesn't have a muscular wall. So if at all the pressure gets more, na, these collaterals will get burst off.
Okay.
So the collaterals doesn't act like the normal vessels stay open for rest of the life. That phenomenon doesn't happen with collaterals because the collaterals doesn't have muscular wall.
Okay.
Yeah, how does the Burgess differs from your case?
Ma'am, in case of Burgess disease, in both of these cases, there's a history of smoking. But in Burgess disease, like this comorbidities, mostly diabetes, they would not be there.
Any specific thing how Burgess differs from atherosclerosis based upon the vessel involvement, Aarti?
Ma'am, usually atherosclerosis involves the large arteries, whereas Burgess involve the small and medium-sized arteries.
Yeah, atherosclerosis involves large and medium, whereas Burgess involve medium and small.
Medium
Yeah,
and small arteries.
yeah.
And how will be the lesion, like your atherosclerosis, whether it is proximal to distal or distal to proximal?
Sorry, sir, I was not able to hear your question.
Like your atherosclerosis, whether it is involving proximal to distal or distal to proximal?
Sir, atherosclerosis is involving proximal and Burgess distal.
Okay. So so what is this rest pain typical? You know any definition of this rest pain?
Sir, continuous aching pain, which is not responding to analgesics. It is present throughout the day and night, and it is also known as cry of the dying nurse.
So what is this definition of critical limb threatening ischemia, CLTI?
Sir, sir, critical limb-threatening ischemia, when it is not responding to analgesics given for more than
No,
two
no, no, no.
weeks.
No, no, no. There is a
Burgess.
specific criteria to call it as critical limb threatening ischemia. It has to classify those four things to call it a any of these four things to call it a CTLI.
Ma'am, when the ischemia is lasting for more than 2 weeks,
Yes.
uh, and when it is associated with gangrenous changes.
No. Any ankle pressure, any toe pressure.
APPR less than 0.9, 0.4,
No.
0.4, APPR less than
0.4.
0.4.
Yes.
Yes, ma'am.
Any toe pressure.
Uh,
Ankle
Ma'am,
pressure less than
Burgess,
50. Toe pressure less than 30.
two pressure less than 30.
Yeah.
So along with that, no, when you are taking any pulse radiography or pulse waveform, so your pulse waveform is showing there are
Mhm.
no any phasic flow in the blood vessels, or it is showing
Okay.
only monophasic flow, or there are absent of flow in the your during pulse wave recordings. So it is suggestive of your CLTI.
Okay,
So
sir.
if you go to your next slide,
Yes, sir.
so can you
No.
summarize why this negative history?
Sir, this fainting, blurring of vision, chest pain, they are like complications of atherosclerosis because the patient can have CNS involvement, which will lead to transient ischemic attacks. CVS involvement will further progress to CAD. There can be intestinal angina, then dilated tortuous veins for asking like the venous involvement.
Along with that, your
Okay.
dilated tortuous vein in a varicose vein. Does your Burgess disease also involves veins?
No, sir.
Hmm.
Burgess
What is Burgess disease?
thromboangiitis obliterans. Yes, ma'am,
Ah,
it involves the veins.
So,
it involves all the three things, right? Artery, vein, and nerve.
Yes, ma'am.
Yeah.
so it involves basically all the system because atherosclerosis is your multiple systemic disorder, no? So you should all ask all these histories.
Yes, sir.
Let's go to the next slide. What is this importance of thrombolysis, Arthi? Sorry, Sakshi.
Ma'am, mostly it is done in case of acute arterial occlusion.
Acute arterial occlusion. Acute arterial occlusion is embolism, no?
Acute limb ischemia.
Okay.
Ma'am, these
Then what
drugs
happened?
like
Then what? Okay. Then what do you think it must have happened? They have already removed uh, the thrombus. Then what is the complication you will see after this thing? What is the most feared complication after this kind of surgery? Today the patient was operated. So at evening 6 o'clock the patient got operated. Tomorrow 8 o'clock the patient had this swollen limb, redness, all these things of cellulitis, sort of cellulitis. So what is the most deadliest complication of the surgery of removing the thrombus? Any idea?
compartment syndrome.
Okay, compartment. What is it called? Any specific term? Reperfusion injury.
Reperfusion.
So whenever you are removing a huge thrombus, it was known while removing the thrombus only you do prophylactic fasciotomy because there is high chances of reperfusion injury.